So, greetings everyone. My name is Jean-Pierre Kekens, and I'm very pleased to welcome today Professor Risch from Yale University. Welcome, Professor.
Good morning.
Good morning. Professor Risch teaches epidemiology at Yale. He received his medical degree from the University of California in San Diego and his PhD from the University of Chicago. After a fellowship at the University of Washington and prior to joining Yale, he was a faculty member at the University of Toronto. His research has mostly been about the epidemiology of cancer. He is the author or co-author of more than 325 original medical research publications. Dr. Risch is associate editor of the Journal of the National Cancer Institute, the editor of the International Journal of Cancer, and a member of the board of editors of the American Journal of Epidemiology. About the pandemic, Professor Risch has authored several academic articles, especially about outpatient treatment. He has also made remarked appearances on national TV, including on CNN and Fox News, and he authored incisive opinion pieces, including in Newsweek in July, and very recently in the Washington Examiner. This interview will be in two parts. First, we will focus on the critical importance of early outpatient treatment for COVID-19, which is still widely overlooked to this day. The second part will be more policy-oriented. We will discuss the current trends with the pandemic and policy recommendations to reduce mortality. So, to start this interview, I would like to ask you in a nutshell, and especially for those who are not aware of the concept and of its importance, can you explain what outpatient treatment for COVID-19 is and why it is so important?
Let me just add one thing, that my PhD was actually in mathematical modeling of infectious epidemics, and I published on that back in 1980 or thereabouts. And so even though most of my career has been on cancer, I've actually done work and have some intuitive understandings and mathematical understandings of how epidemics occur and propagate. Now, as to outpatient treatment, COVID-19 disease, it has really a number of main parts. The first part is that the virus, once it gets into the body, is quiet and is asymptomatic. And in most people, it stays that way. The body fights it off, and one never even knows that one is affected unless you test, and even the tests for it are not conclusive. And so you never quite know 100%. In some people, however, the disease will progress and become symptomatic. At that point, it's a flu-like illness. It can have fever, cough, headaches, muscle aches, sore throat. Some people lose a sense of taste and smell. Not everybody has everything, but in general, it becomes like a cold or a flu. And in most people who have that, it's self-limited. Eventually it goes away. However, in some people who, what we call high-risk people, generally people over age 60 or with diabetes or obesity, or who have chronic health conditions like high blood pressure, or maybe they've survived cancer in the past, or they have asthma or lung diseases or kidney diseases, in a fraction of them, an appreciable fraction of them, the disease will progress to shortness of breath where the immune system overreacts. This is a life-threatening illness called acute respiratory distress syndrome, and people are hospitalized at that point for what is a very severe pneumonia. In that pneumonia, the virus gets into everywhere in the body, almost everywhere in the body, and does its damage, and has to be treated in a very aggressive way to prevent death. We don't want to get to that point. The whole point is, once you know you have this virus in you and you're symptomatic, and you're high risk, we don't want that to happen, to have to go to the hospital. We want to treat it immediately, as soon as possible. Most diseases are treated best when they're treated quickly before they expand and get worse. And the same is true for COVID. And we have to treat it as soon as possible in order to achieve the best results. And this means starting treatment within the first 5 days or so of symptoms. And we have treatments for that. And it's not just one drug. We have a number of drugs and a number of things that are given that work, and they've been shown to be very successful. So that's the general idea, that when the disease becomes symptomatic in high-risk people, it needs to be treated quickly in order to prevent hospitalization.
The recommendation of most national health authorities has been to tell people stay home, and essentially contact an emergency medical service when you have very serious symptoms like problems with breathing. Is that having taken medicine upside down? Is this exactly the contrary of what should have been recommended, or what should be recommended to the population?
Well, yes and no. That the great majority of people are not at high risk, and the great majority of those people will do okay. It will be a self-limited, a short 5 to 10 day bout with a flu-like illness, and they'll recover. It's uncomfortable and unpleasant, but they'll recover okay. There are, however, the high-risk people, and this policy ignores those people. Those people should not sit around, because 5 or 10% of them will develop a much more severe disease, and that needs to be prevented. And if the prevention were a treatment that costs $3,000 or $5,000 or $100,000, something like that, you have to say, can society afford something like that? On the other hand, if you have a treatment that costs $20, you have to say, can the society not afford something like that?
You co-authored an article in the American Journal of Medicine presenting an algorithm for outpatient treatment. Can you tell us about this publication?
So this was a paper. The first author was Peter McCullough, who is vice chairman of medicine and a cardiologist at Baylor Medical School in Texas. And he and a whole group of both Italian and American physicians. I'm the non-practicing one among all of them. They're all clinicians involved in active day-to-day treatment of COVID patients. They pooled their knowledge about treatments that they have seen effective and put that into an algorithm of how one approaches the outpatient treatment. And in general, medicine works best when one has scientific evidence, medical evidence for things that work, and you go in a step-by-step process of who needs what at which point. And that's what they did. They start off with people who are at low risk, who don't need to be actively treated unless they develop shortness of breath. If they develop mild shortness of breath, they can be treated at home. If they develop severe shortness of breath, they have to go to the hospital. So there's a plan, and there's reasons for each step of this plan.
Actually, Dr. Zelenko got his study published, and he found in his situation that there was a reduction of 84% of the need for hospitalization when early treatment takes place. That would be the order of magnitude, you think, if such algorithm would be widely adopted?
I think it's an underestimate. I think that Dr. Zelenko's paper has only 125 or so of his patients. Since that paper was written and submitted for publication, and it took a long time to get it published, since it was submitted, he's seen in total more than 800 patients. And his record in the patients since the first 125 has been much better than his original record. When he had seen 125 patients, he was still learning the best way of treating his patients. He had a main way, but he's tailored it more carefully since that time. And now he has achieved what other people have achieved, like Brian Tyson in California and Brian Proctor in Texas. Other people have gotten essentially no deaths in high-risk people that they treat aggressively and carefully, and they tailor to each person the treatment. But what they tailor with is now a collection of medicines that we know about, and it's not a mystery, and we know how they work approximately, and how they work together. And that's in the Dr. McCullough's algorithm paper, but it's also more widely known for clinicians who want to understand how to treat patients aggressively as outpatients.
So it would basically empty the hospitals, the emergency rooms, if such a approach would be widely adopted?
Well, the main thing is not to worry about the hospitals. The hospitals will take care of themselves. We worry about the patients, and this approach will take care of almost all high-risk outpatients. There may be some for whom treatment is still difficult, will need hospitalization, but a lot of what's done in the hospital can be done at home. People can take oxygen at home if they actually need it. So there's reasons why hospitals are the last source of treatment if patients have to be on a ventilator, which is not a desirable method of treating the disease. Then that has to be done in hospital. But short of that, there are a lot of things can be done at home, not just the first few drugs to see if that works, which it does. That's what we know. That's what's in Dr. McCullough's algorithm. But even more can be done than that if necessary in the outpatient setting at home.
There are many medical doctors today in the US who are practicing outpatient treatment, yet there are many, probably still a large majority that doesn't. What is your message to general practitioners about adopting outpatient treatment for COVID-19?
Well, we have the most bizarre circumstance I've ever seen in medicine, where bureaucrats have told doctors how to practice medicine, and they've enforced that through threats on their practice, on their careers, by medical licensing boards and pharmacy licensing boards in 40 or more states that block what doctors can do legally. The medicines that are available that are highly effective when used starting in the first 5 days are legal medicines. They are not experimental medicines. They've been used in hundreds of millions of people safely. They've been used in billions of doses safely. And in spite of that, bureaucrats think that these medicines are dangerous. The bureaucrats are not experts. The bureaucrats have agendas that are not medical agendas. They are not scientific agendas. They have other agendas that they're enforcing an orthodoxy of policy that has no relationship to medicine, to the practice of medicine, and it has corrupted the whole practice of medicine, and it's corrupted the beliefs of the medical community, of doctors and hospitals, about what even constitutes valid medicine. So in this tilted playing field, doctors cannot even try to practice what they might know is the right thing to do. And this makes it almost impossible. And the doctors who surmount that, for example, the ones that I've mentioned, Texas now has, doctors have the ability to choose what they think is best for their patients and can do that. Doctors there are doing it, but other states, it's much more difficult. Virginia is a terrible state for this, for example. And there are many places now where doctors cannot practice medicine because bureaucrats have told them that they can't. And this is a very difficult situation.
So in practice, people need to know in advance which states to go to and travel? What's the practical recommendation to the population?
The practical recommendation is that if people were free to travel, yes, but travel is very difficult, especially during a pandemic. There are some telemedicine groups that are on the internet. speakwithanmd.com is one, and there are others who are practicing medicine through interview on, like we're doing now on Skype, and are managing patients that way, have pharmacies in states where it's legal to prescribe these medicines and are shipping them by FedEx. Doctors within those states affiliated with these telemedicine groups who are practicing that way and are treating patients. So again, this is a legal thing to do. These are legal drugs, and the practice of medicine is an ethical one. Doctors take a Hippocratic oath when they graduate from medical school, some when they start medical school. This is, the first allegiance is to helping the patient. And that means doctors have to know what's right and do what's right. And many of them are trying to do that in spite of the limitations enforced or attempted to be enforced on them by corruption. And that's the problem today, that the bureaucrats are corrupted and the medical boards are corrupted, medical organizations are corrupted, medical media is corrupted, and the corruption is so widespread, it makes it very difficult for doctors to see the clear path on how to treat their patients by medical reasons that they themselves can figure out.
Another country where there are extremely tight constraints and you can go to jail and get these hefty fines, for example, with hydroxychloroquine, is Australia. And you may be familiar with the work of Professor Borodi, but he was able to convince at least one national media, Sky News Australia, to listen to him. And he came with an early treatment protocol that is now being given by a range of general practitioners on an outpatient basis with the generic drugs off-label. What do you think about what's going on in Australia, and also particularly about this assertion by Professor Borodi that actually COVID is easier to treat than the flu?
Well, Australia used to be a democracy. That's about all I can say about when fear grips a population. They become terrorized by their fear, and the terrorism becomes enshrined in their government. I'm not a libertarian. I think that we have a right to expect our government to help us out of the pandemic. But at the same time, we have to be sure that that total liberties are not being blocked because of theoretical ideas about treating the epidemic that are not scientifically accurate. And there's a balance. So where that balance is has to be determined. But putting people in jail for not wearing masks when mask wearing has different voices, both pro and con, is absurd. And society cannot be ruled by fear. Now, Professor Borodi's idea of his treatment plan is a good one. There's 5 or 6 studies now, including a randomized controlled trial, all showing the benefit of the medication plan that he proposes to use. It's not 100% proven, but it's effective and one of the tools that's usable for early treatment of this disease. As I've said, there's more than one medication that can be used as the mainstay of treating it. And his plan is one very good plan. And given that bureaucrats have corrupted the process of what can be used in Australia, just like in the United States, just like in Canada, just like in Europe, just like in many places around the world, given that one has to work around, if you can't work through something, you work around it, and that's what he's done. And he's very effective in doing that. And it's fortunate that the corruption hasn't gotten to him yet, and I hope he's able to manage to continue that and spread his recipes, because they work just as well as the recipes in Dr. McCullough's paper.
Can you provide maybe 1 or 2 examples that are highly convincing that you know of where early treatment works?
Well, so from me as a person looking at this, when I go to a doctor and the doctor says, well, I've treated 800 patients and 2 of them died, but 798, these were high-risk patients, 798 out of the 800 survived and did well and have no long-term problems. I say, okay, I'll pick that. I'll go to that doctor. I'm not going to go to a doctor who says, well, go home and take aspirin or Tylenol, and then if you get worse, go to the hospital. So take your choice. Which one are you going to go to? The doctor who says and can show you that they've treated 800 or 1,700 patients and done almost perfectly well, or the one who says, I have no idea how to treat it, I'm not going to take responsibility. I think the choice is clear. Now, people have said that when I've talked about clinicians who have shown me stellar records of the high-risk patients that they've treated successfully, they said, oh, well, you cherry-pick the doctors who you report on. So you've only reported on the good ones, and there's a whole bunch of bad ones that you don't know about who are out there in the population. So I said, okay, let's say that you think that that's true. Well, when I wrote my paper and the response letter to the editor back in May and June, I had reported on 5 or so doctors, and I followed up with 2 who were continuing to report. So I asked them, let's see what happens going forward. You've said that this was at a time when Dr. Zelenko had reported on his first 400 patients, and Dr. Proctor in Texas had reported on his first 50 patients. I said, okay, you've said that you can do really well with your treatment methods. Now let's go forward. I'll come back to you in a month or so and see how well you've done since then. And then I did that. I came back to those 2 doctors, and at the end of a month, Dr. Zelenko had treated another 400 patients and had 0 deaths. Dr. Proctor had treated another 140 patients and 1 death. So in that total of 540 or so patients, there was a total of 1 death, and that proves the case that there was no cherry picking of doctors, because I went from them from the beginning and said, prove to me that you can actually do this, and that's what they did. All right, so that's the first point, that doctors who say they have a method of doing it, if you let them show you that they can show you that they can. So that's the first piece of evidence, going forward, not cherry picking, going forward in time, they can show that. The second thing is that there have been numerous studies now, both randomized controlled trials and non-randomized but controlled trials, and they all show beneficial statistical evidence of benefit that is now beyond a doubt, beyond what any rational person would consider sufficient evidence to prove an etiological relationship between the main components of the treatment that's common to all these studies and the outcomes that they prevent, which is hospitalization and mortality. So there's no question that the science shows the benefit also.
Talking about scientific evidence or kind of common sense evidence, you may be familiar with the interview I did with Dr. Tyson out of California. And so he says that he has 0 deaths out of 1,700 patients. Is this scientific evidence?
Well, it is, in fact, because if you asked him a month, or when I found out about Dr. Tyson was also in June. And this is also Dr. George Fareed, who is in that practice in the El Centro area of California, just north of Mexicali in Mexico, which has a large number of people who are actually at high risk. These are indigenous people who are involved in agricultural work in Southern California and have much higher rates of diabetes and other chronic conditions, even for their age, in their age, it's 40s and 50s, than many Americans have, and they're at higher risk for bad outcomes with COVID, and they've treated them very successfully. So when Dr. Tyson said I had treated 1,200 patients, I said, okay, well, let's see how you do. And now he's up to 1,900. So that's another 700 patients that he's treated with no deaths. Okay, it's very difficult to argue that these people are successful in what they're doing. And as I've said, if you are trying to get an accurate number for, in epidemiology, we do what are called case control studies or randomized controlled trials. These, where you compare one group with a treatment to another group without the treatment. And it gets you a ratio number, a numerical value of the benefit of treatment. But we're not actually interested in that here. We're interested in whether the treatment works or not, the fact of it works or not. So you don't really need the comparison group, the control group, when all or virtually all of your treated subjects do better, because you know in your population that there are a large number of people, say over age 60, for whom 10 or 20% are dying, and maybe not at this point in the pandemic, but in April, May, and June, this was the case. And when these studies were being done of the patient collections where nobody is dying in these doctors, and 10 or 15% of patients in these age groups, the same age groups, are dying in the population, you know that the doctors are doing something that's effective.
So when people in the administration insist on randomized controlled trial, despite the magnitude of the difference between the mortality, the zero mortality, and the actual case fatality rates in the area, what's your reaction?
There's two issues to say about randomized controlled trials. The first is that when you're evaluating a benefit of a medication where the benefit might be small, where it might be 25%, 30%, something along those lines, and you need to be very precise and very careful about how to evaluate that, then a randomized experiment, a randomized control trial, a large one that removes all of the possible effects of bias is indicated in order to be sure that there aren't factors that could account for 25% benefit that aren't really what you had in mind from the medicine itself. But when you have a medication that has a 50% or a 75% or a 90% benefit, when the benefit is so large that you can see it in the first 10 patients that you treat that come to your office, you don't need the high quality of a randomized controlled trial necessarily in order to prove that the drug works. That's the first thing. The second thing is, actually there's three things. The second thing is randomized controlled trials are no better than observational studies unless they're extremely large. And the reason for this is a subtle statistical one that's not well understood. What this means is that if in a randomized controlled trial, you assign treatments to one treatment group, patients to one treatment group or the other, based really like flipping a coin. And you know that if you flip a coin 10 times, you're not going to get 5 heads and 5 tails. You might get 6 and 4, 7 and 3, even 8 and 2. That happens by chance. If you happen to get 7 and 3, that means, say, heads is twice as likely as tails. And so if you do a randomized trial with 10 patients, you might have, by chance, that the drug works twice as often than the placebo, than the standard of care group, just by chance. So you can see in a small randomized trial that it isn't large enough for the randomization to make everything equal. The question is, how many people do you need in a randomized trial in order for everything to be equal? And the answer to that is not 500 people in each group. Even 500 people in each group is not big enough. You need thousands or even tens of thousands of people in your trial in order for it to be big enough to remove the biases in the trial, what makes the randomization the tool to be used. And trials are almost never designed to remove bias. They're designed to see, if you say, I want the drug to show that it has a 50% benefit, then we have to calculate that we need 500 patients in the drug group and 500 patients in the placebo group. But 500 patients in each group will not remove enough of the bias that so the trial will be no better than an observational, a case control, or a cohort study in which epidemiologists know you have to account for the biases by statistical methods, which we do all the time. And so that makes your average randomized trial no better than other high-quality epidemiologic studies. And that gets to what has been called randomized controlled trial fundamentalism. People who believe that only randomized controlled trials provide scientific evidence. This is an irrational belief that's founded on extrapolation from what I've just said, that if very large studies are good, then smaller studies are just as good. That is not true. And so if one extrapolates incorrectly to hide behind the fact of only randomized controlled trials provide evidence, this is not scientific. What we've had in epidemiology is we know that our studies can have biases in them. And what makes epidemiology a unique science is that epidemiologists obsess about bias and what we call confounding, the reasons why other factors might account for the results that we see, not the factors that we're trying to analyze. And so we have statistical methods. We measure everything in the world that we think might be going on, and we try to account for those factors and adjust for them and control for them in order to make the scientific statements as accurate as possible. We do this day in, day out in our studies. Back in 1965, the Sir Austin Bradford Hill, who was a very famous epidemiologist, biostatistician in England, set out a paper that comprises the fundamental reasoning of causal evidence in epidemiology and statistics. And in that, he outlined 9 aspects of causal reasoning, meaning a framework for evidence to use to put together a case as to whether an association that one observes is a causal association that reflects causation in nature. And that framework is how epidemiologists, and courts for that matter, evaluate causation, not by relying on randomized controlled trials only, but using all of the evidence available and thinking about how all of the evidence bears upon the relationships that one is studying. And in that context, one arrives at or disproves causation. That is how reasoning is done in science, not by saying, oh, my pet evidence is the only one that counts, and all of the other evidence I'm going to ignore. So this is the problem, that you have groups in medicine that proclaim themselves to be evidence-based medicine. They give themselves a grandiose title while they're at the same time hiding the fact that their methods have flaws, and proclaim themselves the only way of evaluating the evidence for medications, when in fact it's not true at all. The science is totally beyond that, and they have no grounds on a scientific basis to assert that only randomized controlled trials work.
How do you explain the insistence of many authorities and internationally at the European level to have randomized trials with this very large number of patients while there was an emergency, and also the limited response of a randomized controlled trial, in the sense that you basically guess a yes or no answer. You don't get very much of a beyond that. And how do you explain that there was such insistence from the very beginning in February, when the directions of the research were decided upon?
Well, I think that there has been a lot of what I'll call malfeasance in this whole pandemic about how to treat it. And I think the financial interests are so large, they've corrupted the playing field. And that's what is behind the great amount of reliance upon non-scientific reasoning and the corruption of the bureaucracies and governments and so on. And honestly, I think the people have lost. The 200,000 plus Americans who have died have lost their lives because of this corruption. And the whole claim that only randomized controlled trials provide evidence is fake, because we know in medicine that the great majority of drugs used today in medicine were never put through randomized controlled trials. We have, even recently, even cancer drugs that come out of the FDA, that are approved by the FDA, are never run through randomized controlled trials for proof of efficacy. Very common medications never use randomized controlled trials. Antibiotics that we use day in, day out have never been run through randomized controlled trials. The cardiology societies, they did an analysis of the major drugs that are used in cardiology. I think only 8% of them were actually established through randomized controlled trials. So more than 90% of those drugs never had randomized controlled trials to establish them. This is how medicine works. Medicine has evidence. We use evidence, but it isn't only randomized controlled trial evidence. And the arguments about this have gone on for way longer than just this year. In 2017, the head of the commissioner of the FDA, Thomas Frieden, wrote a long paper in the New England Journal of Medicine showing that randomized controlled trials are not the only form of evidence, that they have flaws, that in a randomized controlled trial, if you see a significant result, it's likely to be true. If in a randomized controlled trial you see no relationship, no significant association, it's likely to be false. It's likely to have been messed up by the investigators. And that is because it's very easy to corrupt a randomized trial in subtle ways by investigators so that it shows nothing. And you cannot rely on a randomized controlled trial that shows nothing because of the potential for corruption. You have to know that it was done carefully, and it's very difficult to know when investigators want to corrupt their trials. It's very difficult because they don't publish all the details of what they did. So Frieden wrote about all the real-life problems that trials have and why they're only one type of evidence and why all these other kinds of studies have evidence. At the same time, there are statistical papers in the statistical literature showing the problems of randomized trials and how well they work or they don't work. So there is a large literature now of papers talking about the problems of randomized controlled trials. These problems are ignored by agencies and people who say only randomized controlled trials provide adequate evidence.
To get back to the question of high-risk groups, what's your take about what needs to be done in nursing homes?
Nursing homes provide a double whammy of people at potentially very high risk and at the same time in congested circumstances with care staff who go in and out of those homes and are exposed in other places in the general population. And usually the care staff are younger people who are not at high risk, who may be, who could be carrying the virus and asymptomatic and not know that they're infectious. So there are two things that need to be done in nursing homes and other facilities of senior citizens as well that are similar, which is they have to be protected at all costs and they have to have immediate treatment available to them. Now, let me start with the second point first. Very elderly people need treatment even sooner than people who are at otherwise high risk. And there have been some nursing homes in the United States where the doctors who supervise them have instituted plans of going around to every resident with a finger pulse oximeter. So this is what's practically like a little toy that you stick on your finger. You can buy at Amazon for $30, and you stick on your finger, and after about 5 seconds, it measures how much oxygen is in your blood. And they use these to go around to patients twice a day, looking to see if their blood oxygen has declined. So they know who is likely to be infected, but asymptomatically, and in those people, they start treatment then, before they even have a cough or anything else. So that is a very effective method for treatment. And most of, or all of those patients will survive. The second thing is that the care staff are just like everybody else in society. It's very difficult to know who gets on the airplane, who goes into your store, who does anything that could be infectious. We have ways of testing through what we call PCR tests, and now developing other tests through saliva and so on for people who are carrying the virus. We don't know if that makes them infectious or not. We can measure people's temperature. Places do that as a means of saying to find somebody who might be infectious and doesn't know that. But those tests are not sensitive enough to find people who are actually infectious. And since you have in a senior care facility, maybe 5, 10 or more staff going in and out on a daily basis, that in 10 days, you have, say, 100 opportunities to be tested. If your test is only 95% accurate, which would be very good, you'll miss 5 of those. And that means it's possible that 5 times somebody who's infectious could have come in and started infecting the residents. And so you need a more secure method for doing that. The proposed method is creating a wing in the building where the care staff reside for 14 days before they start providing care to the facility to prove that they're not infectious, and then stay for, say, a month or some amount of time where they reside themselves in order to stay, to avoid being exposed in the first place. This is a very severe limitation on workers and very difficult to implement, but there have been some places that have implemented plans like that. So those are possible ways of dealing with it. In fact, it's probably impossible to completely prevent infectious people from getting into the facility. And therefore, you absolutely need immediate treatment as the backup plan, if not the main plan, for preventing life-threatening pneumonias in the residents.
What about prophylaxis?
Prophylaxis is a good point. It's another possible method of preventing hospitalization and mortality. Prophylaxis has been studied by medication usage in generally smaller amounts in steady state, in just long-term usage. And there are 4 studies in India that show that prophylaxis of medications work. There are some other studies. It is not as strong a benefit as early aggressive treatment. Nevertheless, there is evidence that it does work and in fact could very well be used. But you have to remember, elderly patients tend to have more chronic conditions and need more careful evaluation to know that the drugs being used for prophylaxis are not contraindicated, that they won't have some chance of untoward effects by taking them. In general, these drugs are extremely safe. They've been used by billions of times by hundreds of millions of people, and so they're extremely likely to be safe regardless of that, and should be entertained and considered for prophylaxis as well. That's a very good point.
But what about just vitamin D and zinc as I think there are indications that many older people tend to be deficient.
Yes, and probably everybody over 40 should supplement with vitamin D and zinc, regardless. That living large fractions of our life indoors in modern society tends to have reduced vitamin D production, and for whatever reasons we don't get enough zinc in daily life, especially in older people. The comorbidities, the chronic conditions that people have as they age tend to be associated with lower levels of zinc, and so supplementation of zinc is important. Some people are concerned that zinc can deplete or overshadow copper usage. However, copper supplementation is not indicated. There's now evidence showing that excess copper intake in the form of what's called divalent copper with a charge of +2, has, as it is in supplements, has increased risks of Alzheimer's disease when exposure occurs in long term. And so there's a question. Normal copper that one takes in food is copper +1 charge, not copper +2 charge, and that's safe. So it's hard to know, but in the present time, for the next 6 months or a year, people are not going to be at risk of copper alterations by taking zinc supplementation. And that's what we need to establish now. And we'll deal with copper over a longer term. But for now, older people who are zinc deficient need zinc supplementation.
Okay. So this concludes the first part of our interview, and we'll resume in a few minutes.